welcome to today's Samvaad-Talk by Professor Subhajit Sen. I'm sure you all know his impressive resume and credentials, so I don't need to get into that in too much detail. The only thing I just found from his website is he firmly believes analog processing is here to stay, how much ever digitization we do. So he's going to talk to us about ultrasound, he and his student. Thank you.
So this was some work that we started in 2014. Is a culmination of work of 3 or 4 students. Actually, it came to us as a challenge from Dr. Vikas. As you know, we have lots of projects going on with Nimhans, and they give us they give challenges to different professors. So Dr. Vikas gave me one challenge. We are doing this surgery for brain. They do lots of surgeries for brain, these surgeries, they have to insert what are called catheters or sharp pointing devices into the brain. But a similar kind of pointing of surgical objects into different parts of the body do exist. Kidney, liver. You have to extract fluid. Particular region you have to. So now when you insert that object, you may not, unless there is an image. So some image of that object, of that tissue, you will not know whether your catheter is, or that cannula is going in the right direction. It is penetrating the right organ or not. So there is failure rate. So he says that how do we, can you do something? Can we do something for improving this failure rate to make it image guided? Now imaging is there. They have PET, all these techniques are there. MRI, PET scan, CAT scan is there, but they are not very friendly for surgical environment. So because they require special enclosing casing, and so you have to you need some kind of an image guidance, but that imaging modality has to be has to be chosen properly. So why not the best imaging modality, which is very safe, relatively simple, inexpensive, is ultrasound. So can we do? So when I started this project, I had no idea what I was getting into. So this was a unique opportunity, being in an academics, professor's time, you do this, and so that is one also students, when you being in academia has that advantage. In industry, you spend so many years, you never dream to do this. Academia this is possible. You're something that fascinates you, you go to the logical end. But as I said, I had absolutely no idea about what I was getting into, what is the technology involved. So it was actually a project started from scratch with almost high school level of understanding of physics and physics. So that was the whole thing. So this, and again, another reason is I chose this topic is it is multidisciplinary. Yeah. So you start with what is called the transducer, and the transducer is a material. So that material is a piezoelectric material of special type. So first is, how do you get that material? Who's going to give you? You cannot buy it from the market. Can't go to SP Road and buy these things. So this is first is understanding, who does. So then, there were these challenges, and then and slowly I'll tell you how we overcame these challenges. The second aspect is of the multidisciplinary physics of propagation of ultrasound. Okay, it's a wave propagation. We know that. Okay, so now wave propagation, we stopped studying waves after high school, after class 11, Young's interference. We stop. So then you have to re-educate yourself. What is wave propagation? What is near field, far field? So all that education, I had to re-educate myself, and with the help of Ahish. So I learned from Ahish, more than, okay. Then there is a third aspect is the space-time signal processing. This is no longer simple linear time processing, DSP or signal processing. It's space and time, yeah. So because the beam has to be directed in a certain way, So this we have multiple elements and we have to phase them. Okay, although our research currently was on one transducer, but in generally we have ultimate ultrasound is phased array processing where you do beam steering. We have not done beam steering so far. Okay. And the other aspect of the multidisciplinary nature is the analog and mixed signal processing. That is always there. You need very low, because the echo signals are very weak, low level of signal in a highly noisy environment. So how to filter it, signal conditioning, and then this is also has to be done. Then signal processing has to be done. Okay, and then it has to be done in FPGA processing because the sampling rates are very high. But that again, this very high sampling rates cause other problems. You have to interface boards, so there is noise and all that stuff. The reflections between transmission lines and all that stuff is there. Yeah, and then finally there is DSP on FPGA processing. Okay, so so the one difficulty that we faced is that the most important, the hardest thing to enter this kind of field or any field involving specialized hardware and specialized kind of this thing, they're in optics or in the case of acoustics, is getting the transducer, because we don't know how to get it. They are not available, as I said, in the market. You do Google search, you will not get. So only people who make these transducers are specialized labs. Naval Research Lab in Cochin, okay, DRDO, specialized DRDO labs. Now they will not do it for you. Their time is precious. It's hard to enter into these. So how? But I still got what. So what I did was started with these Chinese transducers. They use that for emulsifying liquids, cleaning. Yeah, very high frequency 2 megahertz transducers they used for cleaning electronics. I started with that. And then we moved into more sophisticated transducers using NDT for use for testing of materials. Like Sachit, you would know, they send, you want to test cracks in materials, they use ultrasound for this. So then we went into those kind of transducers and ultimately procured one transducer. And now we are going into array. So I'll just give you a glimpse of what he has done to get an ultrasound signal, echo signal, and image signal for this brain surgery applications. One application, but you can use it for any other organ. So without further ado, I will request Ahish, my dear student.
My name is Ahish KN. I'm a second year MS by Research student under Professor Subhajit Sen. So today I'll be talking about real-time image-guided surgery using ultrasound. So as you all know, the medical ultrasound has been used from a long time. So it's a non-invasive imaging technique used in almost all the hospitals. So they use ultrasound waves to get the image of. It is predominantly used for examining fetal health, for viewing internal organs of the body, like liver, pancreas, and gallbladder. So the ultrasound imaging technique gives real-time images. So the real-time images are obtained by sending in ultrasound waves into the body, and the tissues in the body echoes the sound back. So by capturing these echoes and accumulating them and then it gets displayed as an image. So ultrasound is basically a sound. It's a category of sound waves which have frequencies above 20 kilohertz. So diagnostic ultrasound used for imaging purposes, they use sound waves which are in the frequency range of megahertz. So the ultrasound imaging system, it has a probe through which ultrasound is sent. And
explain why we want to use megahertz instead of 50 kilohertz.
So typically sound waves in the range of few hundreds of kilohertz or few tens of kilohertz, they have good penetration into the body, but the images which you get out of them, they are very blurry. They have low resolution. So that is because the tissues which are there in the body have fine details which have to be captured. So that's the reason Yep. Yes. Yes. No, that is in process. Yes. 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 Yes, Professor. Yeah.
So the wavelength is smaller.
Yeah. Yes. So the ultrasound probe contains several acoustic transducers. So to send the ultrasound pulse, these acoustic transducers are made of piezoelectric crystals. So whenever change in electric pulse is applied across these crystals, a corresponding change in mechanical stress occurs across the crystal. So this effect is called piezoelectric effect, which is exploited in production and reception of ultrasound and in their echoes. So these are the parts which are involved in a ultrasound transducer. So there are two important layers in the transducer. One is the backing material and one is the matching layer. So the matching layer is present in between the piezoelectric crystals and the face of the transducer. Its presence is predominantly to match the acoustic impedances of the piezoelectric crystal, and so that maximum energy is brought out from the piezoelectric crystal to match the acoustic impedances. The backing layer is there to support the piezoelectric crystals, but it's the material which is used to make it is also extremely important, because the backing layer is the layer which damps the ultrasound signals. So whenever we give an electric pulse, if there is no backing layer, the piezoelectric crystal resonates. So by giving one single pulse, we'll be getting several ultrasound pulses. So, but what is expected in a good transducer is whenever we give one single electric pulse, we expect it to give a few or one ultrasound pulse, the mechanical pulse. So to basically attenuate or not let the piezoelectric crystals to resonate, there is a damping material. It's called the backing layer. So these transducers are the damping of the backing layer is measured using a parameter called Q factor. So the transducers with high Q factor, they have backing materials made of low damping. So, and also since they have their damping is low, they have a narrow bandwidth. So similarly for a low Q factor transducers, they have backing material with heavy damping, and they have a broad bandwidth. So sorry, sir. So no, sir. It's showing that it has a wider bandwidth. That's all. So once an ultrasound wave is transmitted through the body, whenever there is a mismatch in acoustic impedance in the medium, so a part of the transmitted ultrasound wave is reflected back, so which is called an echo. You can see in the video that it reflects back. So the strength of the reflected signal is calculated using that equation there. So it's calculated. The R is called the reflection coefficient, and A1 and A2 are the
A is acoustic
impedance of respective materials. Yeah.
There is two materials that there is interface. So the difference in the acoustic impedance will tell how much the incident wave is reflected back. It follows the principle of
optics.
Microwaves or whatever. This is a common equation with wave propagation.
Yeah. So typically ultrasound, since it's used in diagnostic purposes, it's a real-time technique. So it can also be used for assisted surgery. So one of the applications being a physiological condition of the brain called hydrocephalus. To understand this condition, a little bit of brain's anatomy is required. So as you know, brain is a central processing unit of the body. It consumes a lot of energy in a day-to-day life. So this energy is provided by the circulatory system of the body. There's an extensive network of blood vessels which go around the brain. But the blood vessels can't reach each and every part of the brain. So to compensate for this, there is a fluid called cerebrospinal fluid. It's called CSF. It flows through the cavities inside the brain. These are interconnected cavities, which is shown in the below video. So these cavities are called ventricles. So CSF flows in ventricles, and it is almost like water. It has salt and other nutrients, and the brain tissues absorb these nutrients from CSF. So what happens is there is a tissue called choroid plexus in the lining of the ventricles. This tissue is responsible for producing CSF. So in certain conditions, what happens? Whenever there is excessive production, or whenever there is slower absorption, or whenever there is a blockage in ventricles, this CSF starts accumulating in the ventricle. So brain being a very soft organ covered by a rigid, strong skull, it is a very soft organ inside. So once CSF starts accumulating, the internal pressure of the brain increases. So this causes a lot. This is very critical and dangerous, because the small blood vessels which are there supplying blood to the brain, they rupture or they clot. So it leads to brain hemorrhage. Most frequently, it leads to death. So it's the maintaining of CSF in the ventricles is very critical. So the condition where this inflammation occurs, the swelling up of ventricles, is called hydrocephalus. So this condition is very common in all age groups. So you can see, so a small child, since its brain has not yet developed, when hydrocephalus occurs, its brain swells up. But this swelling of brain, is not common in. You can't see it in adults because they have a properly formed skull and so on. But still, they have symptoms of headache and all that. So a surgery for the treatment of this condition, a surgery called ventriculoperitoneal shunt, is done, where the doctor during diagnosis takes a 3D MRI scan of the brain, and he knows exactly where the ventricle is, and he plans a target location through which he inserts a catheter, so that he punctures the ventricle through the cerebrum of the brain. He punctures the ventricle, provides a bypass path for the CSF to come outside the ventricle and flow to the abdominal regions of the body. So this surgery, so he places a shunt, and there is a valve which controls the amount of CSF which flows out to regulate the flow. So while the doctor pierces the catheter inside, he has only one chance to do it right. If he doesn't hit the ventricle, it leads to several other complications in the surgery. So this is one of the places where assistive surgery can be very effectively used. So because of this inaccuracy, where he uses his intuition, and because of this inaccuracy, the success rate of the surgery is low. It's just around 30%. So ultrasound based non-invasive guided surgery will improve the success rate. Yes. So first they drill a hole. No, Professor. It will be too complicated because he has to puncture it. So if the path is not a straight line, it's hard to push a strong metallic thing through a circulatory or a wavy path. Yes. They actually drill it. So okay.
But for some reason, they don't, maybe because of access. To do it through nose,
Yes.
You may not be able to, because there might be intervening organs which will damage. Whereas if you do it through the skull, you just have to enter the dura and the gray matter, and just directly play.
The amount of the brain is a very redundant system. It has not all parts of the brain is working all the time. So there are some parts which are inactive completely. So they puncture it through those areas. So that's also. So to transmit an ultrasound wave, which it is generated. There's a circuit called high voltage pulsar, which generates this high voltage electric pulse, which can be applied to the transducer. The input to this circuit is a low voltage signal, as you can see there. It is typically controlled by processor or controlling units within other part of the system. So once the ultrasound is transmitted, the received echo is diverted to another part of the system where it gets processed and all that. So there is a switch which switches the transducer from high voltage circuit part to the echo processing part. It's called a TR switch. So we use only one transducer for both transmitting and receiving here, because it is extremely hard to make replicas of the same transducers having very close frequency responses or characteristics. So if we apply the previous equation that we had seen, we can see that so the impedance of brain tissue is 1.6 megarails, and that of CSF is 1.5. So the echo which gets reflected from this interface between brain tissue and CSF is extremely low. It is just 0.01% of the transmitted pulse. So the echo strength is extremely low, and over which there is all kinds of attenuation, which when the echo passes through the medium of the brain and before reaching the transducer for reception, so there is scattering and there is absorption of echo. It gets absorbed, gets converted into heat. So over the 0.01% of the transmitted pulse, the strength even reduces further. So we need specialized circuits to capture these signals. So that's the reason we need something called an AFE, which I'll be explaining. Attenuation is modeled by observation. It has been modeled that it has an exponential nature. No matter through which material, no matter what the medium is made of, it has an exponential nature. And so there is a parameter called alpha, which is called the attenuation coefficient, which characterizes a medium. So different mediums have different alpha values, but they all provide a exponential natured attenuation. So you can see at the top of the diagram, the interfaces, all of the interfaces, the light gray and the dark gray, between which there are interfaces. So, yeah. Yep. So these are the interfaces. They all have same differences in acoustic impedances, but their corresponding echo which has been received, they are of lower amplitude. That is because of the attenuation through which attenuation offered by the medium the echo has to travel. So a technique called time gain compensation is used, where the received electric signal corresponding to the echo are amplified in time. So it's a time variable amplifier which they use to implement TGC. So after TGC, you can see that the echo amplitudes they almost have the same peak to peak value. So yes, so we use as already told, the strength of the echo is extremely low. So we use something called analog front end, which is specialized for receiving low voltage signals. So this analog front end is a system which involves several subsystems of circuitry. So first one being the LNA, which is called the low noise amplifier. It is a simple amplifier, but it offers very low noise to the signal. All the electronic systems have noise within them, which they add to the signal which has been received. So a low noise amplifier is used since the echo is of very low strength, and then a TGC circuit will normalize the echo signal, and then it goes through an anti-aliasing filter so that it can be converted into digital data through an ADC. So here, since the ADC is typically of high speed, because the echo signal itself is in megahertz. To sample it, we still probably we go for 40 or 50 or sometimes 100 megahertz of sampling rate. So and once the ADC samples and converts the data, so it might give out data in 16, depending on the resolution of the ADC. It might give it in 14, 16, even higher bits. But transmitting data parallelly will have timing skew in timing. So to avoid that, there is a block which converts parallel data into serial. You can see that the 8-bit value has been converted to a voltage of to a digital signal of either 0 or 1 in one using just one line. So yeah, no, yes, we actually don't know the exact variations in the tissue, but on an average we take a value. That's all. That also gives an artifact.
To know the relative alpha value, get how much you can compensate here. Whatever you know. What are the parameters for that PGC? Yes. We have not done TGC.
No, we are not done. We wanted to differentiate between the echoes. So for example, if we trigger the ultrasound transducer using a 5 megahertz electric pulse, the echo will also be will have a center frequency of 5 megahertz. So you can see we are giving a square pulse, but it is attenuated sine pulse or a Gaussian attenuated. So its frequency response varies. So so we need, according to Nyquist criteria, okay, we need a 10 megahertz sampling rate. But to get the details of the echo, capture the variations along the curves of the echo here, these variations, we usually sample it at a higher rate, 40 or 60 megahertz. And if the ADC has a resolution of 16 bits and we are serializing the whole data, then the bandwidth of the output digital signal reaches around 1 gigahertz. So this is high speed data coming in serially, which these kind of data cannot be handled by typical microprocessors which we see. So that's the reason we use something called a field-programmable-gate-array for processing in hardware. Yes, sir.
But your incoming voltage signal is very weak and you have amplified.
Yeah.
So how do you justify the jump from going from 250 to 11 you can do it?
You mean? Yeah. Yes. Yeah. Yeah. Yes. Yes. No, actually we have captured the analog signal, sir. Yes. Yeah. Yes. Yes. Right. Yeah. No, sir. No, professor. So when we get the millivolt signal, we scale it to say 0 to 5 volts. It's going to. No. After in this slide, if you see, so up to this point, the signal is in analog domain. Yeah. So here it gets sampled with a resolution of 16 bits. Yeah. Yes. Yeah, greater resolution of 12 bits. Yes. Yeah, yeah. So this depends on the contrast of the image which we want to see. If we want a detailed image to do proper signal processing, then we go for higher resolution, higher ADC, higher resolution ADC. Yes. Because human beings can only do about 32, 33 levels of contrast. Correct. Yes. Just 8-bit itself is 2. Yes. Yes. Yes, professor. Understood. Yeah. Yeah.
Dynamic range would go from maybe a millivolt to several volts.
Yes.
Reference voltage?
2.4.
2.4. So it will be sub-millivolt. It can be 100 microvolts. So 8-bit is not enough. 12 bits, 14 bits is what they recommend. For medical images, what you see is that the very high resolution to create artifacts. Yes.
Right.
So your input resolution, let's say your input is only 300 levels.
Yeah.
But you go for 1000 levels. There is interpolation occurring between from 300 to 1000.
Correct.
That can create artifacts.
Okay. Okay, sir. Okay. Okay. Yes. So. I mean, the point which I wanted to make is the digital signal through which the data is coming, it reaches almost a gigahertz, more than that typically. So this high-speed data cannot be processed using typical processors, even though with 4 cores, quad cores, no matter how many cores, because of their architecture. So
what is your high-speed output? I don't know if they
do use FPGAs.
You have a big electronics one and all chips. Not even FPGAs, customized data set chips, even much higher than FPGAs.
Yeah. So typical difference so the need for an FPGA here is a normal computer, when you write a program, give an instruction to a computer to perform, it takes at least 3 clock cycles for it to execute. Say it has to fetch the instruction from memory, it has to decode the instruction, and then it has to execute using its arithmetic logic unit. But in FPGAs, this is not the case. What happens is when you write a code, a specialized hardware is created within the FPGA, which is very specific to the code which you have written. But whereas in a general purpose computer, the hardware is already present, only the new program is fetched from the memory and executed using the 3 cycles. So for example, if you take shift operation, the general purpose computer will at least take 3 clock cycles. Even if it has a barrel shifter, which takes 1 clock cycle for execution, the other 2 clock cycles will be taken for fetch and decode. But if the same thing is implemented in FPGA, the bus, for example, if the variable A is an 8-bit value, it's right shifted by 2 units. What it does is it changes the bus placement, the interconnect placement, and it implements shifting operation. So it changes the hardware. So because of that, the shifting operation is performed instantaneously, or it takes around 1 clock cycle if you want to store the data, if you want to latch the data. So so this is the system which we have implemented. It is we have implemented it for one single transducer. It doesn't have multiple piezoelectric crystals. It has one piezoelectric crystal using which we can capture one echo for how long duration we want. So it has an AFE high voltage pulsar. The AFE has all the internal blocks in it. So the FPGA we are using is from Xilinx. So now I'll show you the demonstration of how transducer is placed in the brain and how an echo is generated. So this is the model which we had made for a brain. So we have closely matched the acoustic impedances of brain tissue and CSF using water and oil. They have very similar acoustic impedances. The brain tissue is very close to oil and water. The difference between them is very close. So you can see that as the transducer, as it goes in, we can see the echo moving in time, in position. So yes. Yes.
You can also have also know whether you're moving closer to the ventricles or away from the ventricles.
Yes.
So that's like just
yes.
And you also get multiple echoes. If you see, that tells you the depth of.
Yeah. So yes, sir. In the oscilloscope.
Top wall and bottom wall both you can.
Yeah. So we can see two peaks in the oscilloscope, where one peak corresponds to the interface between oil and water, and another peak corresponds to this part. Yes. Yeah.
That is an indication that there is another bottom wall.
Yeah. Since we were holding the transducer manually, there is a lot of shaking in the hand. That's why it's not. There's wobbling of the echo, but. You can see these two. Yes.
No,
this is.
You guide it down, up and down. That echo position will change. What do you know where? You know where where it is.
No, Professor, what they do is, for a constant depth, they insert a metallic rod through which they insert the shunt. So the metallic rod gives a. For demo, yeah.
What is using what? You don't have, you want to robot meaning you have to insert a moving. What do you need to hold it steady? So hold it steady and tight.
So this.
So he had that.
We had made an arrangement, but.
Yeah.
Okay.
Have it steady.
Yeah. So there's another demonstration where the transducer is moved in an angle across a sector. So whenever the transducer's phase comes in parallel, close to parallel to the interface plane, there is an echo which can be captured. No, sir. As I told, we calculate the attenuation according to those equations. If you get through the channel depth, calculate the attenuation theoretically, and what is the voltage we are getting parallelly. We can compare that. Yes. The thing is, we can't. So to test that, we have to have a prototype where we know we have two objects placed at that close distance.
It can be done.
We have not done that.
One advantage with this is, I think you can afford to have very low tolerance. You are far away from the target. But as you go closer to the target, your tolerance will become low. You don't know where it is.
See?
No, the echo
And you can afford, a lower tolerance.
So you will recognize, surgeon will recognize the echo and immediately know that the ventricle is
Yes. Yep.
See here, when they are far away from the separation, they are far away. They can say, okay, it's 3 millimeter plus or minus 1 millimeter. Then, because using this echo, as they guide this in, it can become smaller, 1 millimeter plus or minus 0.1 millimeter.
How do you can make it smaller?
Yeah. So as it comes closer, your tolerance can also your zone. You can say it's 1 millimeter plus or minus 0.1 millimeter. So you were talking about that.
X-axis is time.
This one.
Yeah. So it's directly proportional to distance. Because the echo takes, we know the speed of. Yes.
Divided by velocity. Simple. Yeah. Yes.
Yes.
Yeah.
Yes.
So
Yes.
as
Yes.
you move, you don't have to move this thing doesn't have to move down. See, once you know that you are hitting in the right angle, all you do is insert the surgical.
The shunt.
This thing doesn't have to go in. The transducer doesn't have to go in. It can be just on the surface. Once you are seeing the echo, you know that you are hitting the right angle. Then you insert the. You should have put that
Cannula.
It's already programmed that robot to keep the optimal. You already programmed the robot so that it will minimize the error. Closed loop system.
Okay.
Oh, okay. So yeah, it does not have to penetrate. It is just for showing that.
Yeah. In surgery, it doesn't. Yep.
It's already programmed. Mentally, it's already programmed. Robot for closed loop.
Yeah. Closed loop.
So this is what we have done using a single element transducer. So we have plans to get an image, construct an image using multi-element arrays and 8 mm. Yeah. Usually the surgeons make an 8 to 10 mm hole in the skull. That's the reason we have chosen. And also the diameter. No.
You have to make it. The transducer have to become smaller. Transducer have to become smaller. Frequency has to be also. High voltage anyway you need because to excite those. You need more energy.
Because the echo is lower, Professor. That's why. Because the echo strength is lower, we increase the input voltage so that we get a stronger ultrasound pulse.
The first question everybody will ask is, it's not very brutal.
Yes.
What is the difference between this and what people do
common ultrasound as in?
You cannot fit it in 10 mm. The transducer itself is.
The transducer itself is around 10 centimeters wide. Yes.
You have to make a big hole in the brain. Then put
this. Professor, this is. Yeah. Okay. Yeah. Yes. Yeah. And everything which is there in the hospitals right now, it's all IP. No one knows how it works. Yeah. So we are So we are trying to. So the theory is present. All the papers are present. The theory is present. We are making a machine. By the way, other countries have made ultrasound machines. India has yet to be. They have not yet made a ultrasound imaging system yet. We are only using machines made by Philips, GE, and they're all extremely proprietary.
We are programming those machines, but we are not building the hardware.
So if you change the fluid inside them, will you have to reprogram your array?
No.
Without parameters.
As in, so the design of the transducer is itself a separate field. I mean the diameter, the dimensions of the transducer. So right now we have chosen 8 mm because the interface between the oil and water is at around 4 centimeters, 3.5 to 4 centimeters. So the 8 mm diameter transducer will have a focus at that depth. So the hardware doesn't change, probably the transducer will change if we change the materials and all other. Yes, yes, that's the next part, yeah, which I'm going to explain. Yes. Yeah. Yes. Yeah. Correct, sir. Yes, definitely.
Blood vessels there in the it's all gray matter. Blood vessels are usually in the side.
It will be surrounding the brain, but they'll choose a location where there is no blood vessel. They don't want to. Yes. Yes. Yes.
So you will also get echoes from the blood vessel, right?
So when you're telling in this path.
Or your angle very sharp.
So, in this path. Yes. So in this path, Professor, so the blood vessels are on the surface here. They are not inside. So to provide nutrition inside, there are ventricles. That's the whole point. So what happens is, this is the brainstem.
When you insert your tube through which you introduce the transducer,
Yeah.
the tube cannot go all the way to the ventricle.
No, it doesn't. It just stays on the surface. Yes.
Once you insert your transducer here, let's say there is a resonance of this kind.
Yes.
If your signal hits those levels, you will get a
Definitely will get an echo. Yeah.
The upper this thing is he has not completed the processing. There is some more processing called IQ demodulation. There is a more complicated envelope detection. He has not implemented. That's why it's more noise.
And its frame rate is also low.
You cannot able to see this. The scope you can see. The upper one is just a proof.
even in the lower scope that day, we noticed that there is a lot of noise coming.
Yeah.
The scope probe.
Yes, yes. So we have.
Scope probe itself was noisy.
Yes, it's very noisy.
So there is a lot of cleanup work there.
This signal is the same scope that is
Yes, 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 yes. But the noise which is being seen in the scope doesn't come into the processing unit. It's only because the scope is acting like an antenna. So we want to make a system where we can get images. So there have been several techniques of getting this done. So here you can see there is a transducer array called linear array. So this linear array has small elements, around 256 to 512 elements.
You have to wrap up quickly.
Yeah. Okay. So 10 to 15 elements are fired at the same time, so that we get an ultrasound pulse and an echo is received. This is done for all the adjacent set of 15 elements. So you get 10 or 15 or 20 echoes, different echoes, and they are arranged side by side to form an image, where the amplitude of the echo is proportional to the brightness of the pixel. So and to increase the field of view, there is another transducer where they have placed the piezoelectric crystals in a curvilinear fashion. So the transducer itself, now the ultrasound wave covers more area, so we get a wider image. So earlier people had tried to do the same thing using single element transducer. What they had done was they connected it to a motor and rotated the transducer at different angles, got echoes at all the angles, and made a sectorial kind of an image. But this has limitations because it involves mechanical motion of the transducer. So the frame rate will be lower of the real-time video. So they came up with electronic steering. So what happens here is the electric signal given to the transducer are not synchronized. Each transducer is fired at a different point of time. So because of that, there will be constructive and destructive interference which occurs, and because of that, the resultant beam moves at an angle. So this is the beam is directed using electronically, not manually. So this is what is being done nowadays. So, and there is another concept called beamforming, where a beam is the piezoelectric crystals are fired such that there is a maximum constructive interference at one of the points in the medium. So they calculate the delay values at which each of the piezoelectric crystals should be fired, and once they get fired, they have a constructive interference at one particular point in the medium. So because of this, even with a lower voltage, we can get a strong we can send a strong transmit pulse, so we can get a good echo.
You get a specific focus point.
Yes, yeah. So in and around near the focus, the echo deflected by the medium will be strong. So, yeah. Okay. Yes. So while transmitting, also we give appropriate delays. Even while reception, we'll have to give appropriate delays before summing all of them. So that's called receive beamforming. So this is a small video which will show how an image is formed. So you can see here, these are the delay values. You can see the pulses are delayed by a little bit for every echo that is acquired. So as this is being done, each echo acquired is a line in the image. So this happens for typical ultrasound systems nowadays have frame rates greater than 100, 200. So each image is happening so fast. This is all possible because of the FPGAs, and even the signal processing which goes on. So there is scan conversion. We can't. So since this is in a since we get data in polar coordinates, we can't fit it in a square, displace a square which are rectangular coordinates. We can't fit it, so we do approximation. It's called scan conversion. We do interpolation. All this is done in hardware, where you coded it so that there are specialized circuit formed instead of using a general purpose processor. So to get the image, we have done some simulation also, where we have used MATLAB. There is a toolkit called Field-2, through which we can do ultrasound. We can simulate the pressure patterns created by ultrasound. So we had set up a phantom. We had done a phantom.
4 man ultrasound. You don't even have an array.
So we have two different materials of different acoustic impedances simulated, and we have simulated a linear array with 256 elements, and so we got this is the image which we had got, and the same simulation we had done for a circular disc also. So we know the process of how to do the image. You know, we have to develop the hardware. And yes, sir, I've introduced some noise, the random noise. Yeah. Yes, sir. Additive Gaussian noise.
You have to define catheter.
Yes.
So those catheter
upon those I have introduced noise, sir, for the whole medium. Because I had to, because the medium is ideal in simulation, I had to make it realistic a bit. Thank you, Professor. That's all.